participate in this conference. This last session was fantastic. And notice when she would read my bio, it doesn't say anything about preventative health, and it doesn't say anything about smoking or smoking cessation. I learned as much doing this talk as I would probably teach you. As we talked about in the last session, I'm kind of at the top of the food chain when it comes to practicing medicine as a surgical oncologist, and when they get to us, there's really not anywhere else to go. And so we don't talk a lot about prevention and smoking cessation and eating right and all that kind of stuff. Those things have to exist at our cancer institute to have it certified, but really it's about, can we take it out, or can we radiate it, or can we give them some more chemotherapy? This has been eye-opening for me and my practice, and hopefully some of the things that we're doing at UT. I am open. This is interactive. This is not me talking to you or educating you. I want to learn from you because a lot of you have a lot more experience in this than I do. I want to talk about soluble malignancies that are associated with smoking, and I will refer to, I don't know how many of you have had a chance to look at the Surgeon General's report from this year, talking about the progress we've made in the last 50 years as it pertains, especially as it pertains to smoking. I will specifically refer to Chapter 6 if you want to go back and look at that on your own. And I told the last session that chapter is about 200 pages. So you can really just narrow that down and go to the next to the last page. It gives you a summary statement. That is one page, and I'll talk a lot about that, so just for your reference. We want to talk about how smoking impedes the optimal treatment of some of these solid cancers. And we're going to discuss the impact of smoking on the future of cancer trends. And we're specifically, my area of interest, as she said, is GI cancers, but specifically within GI cancer, I concentrate on liver and pancreas cancer. And this is a big week for that based on an announcement that was made on Monday, and I've actually got that slide in here. This is a report, this is 1964 Surgeon General report that talked about smoking and health. Basically summarized, the Surgeon General had the guts to produce this and say smoking was bad. Up until that point, there was a lot of tobacco was king, and I grew up in the tobacco capital of the world, so I understand that. I grew up in Eastern North Carolina, and then I grew up tobacco farming until I was 19, summer of my freshman year at Florence, and my county and the adjacent county were the #1 and #2 tobacco producing counties in the world, so I get it. But now, we know smoking is bad, and we're not afraid to talk about it. So we look at the progress we've made in this year's report, and some of the areas of continued opportunity in that. Reasons to celebrate that report this year: significant decline in the smoking rate, in the number of people per 100,000 that are smoking. Now the overall number is not declining because obviously our population has changed in the last 50 years. We've got a lot of tobacco-free environments. That's been a huge change. We've been tobacco-free for 3 years at the University of Tennessee Medical Center. Tobacco-free on paper anyway. A lot of people still smoke on our campus, and we're talking about having the courage to address that. And nicotine addiction and addiction to the metabolites and all those kinds of things. We know a lot more about that now, and we're starting to address some of that addiction and having some alternative methods to wean people from nicotine and all those kinds of things. Reasons for continued concern: cigarette smoking still causes nearly 5 million deaths a year. That's a big problem. Tobacco accounts, from my standpoint, for at least 30% of all cancer deaths. Now, to put that in perspective, we're talking about 1.7 million people are going to get cancer this year. 550,000 people are going to die from cancer. So you get rid of the tobacco, and now you're talking about 350,000 people. So that's an immediate impact. There ain't no surgery, chemotherapy, radiotherapy that's going to do anything like that. Although we spend all of our money on that, and robots that cost the hospital, I see Wellmont right there, cost the hospital $1 million a pop. They're not going to do anything for cancer like that. 45 million Americans still smoke. When that first Surgeon General report was put out in 1964, about 43% of adult Americans smoke. It's now about 21%. That 21% doesn't apply to where we live. Is everybody from this region, from Appalachia? In Appalachia, it's not 21%. It's up to, depends on what you read, it's about up to 33%. And that's probably more like my population, 33%. A lot more kids smoke. 78% of this 21% smoke on a daily basis. And 50% of these people are going to die prematurely. Not necessarily from cancer, but from all cause smoking-related illness. Smoking is a financial burden for this country, attributing to economic costs approaching $300 billion, and direct medical costs is $180 billion. And when you're talking about the Accountable Care Act and prevention, this is big, because we're trying to save money. Reimbursement, I don't have that on here, but in my MBA class, I put together tracking our GI cancers over the last 5 years, and our numbers went up by almost 60%, and our reimbursement curve had a negative slope. It went down just like this. Our cost stayed stable, reimbursement went down just like this. So the only way we can get better is to cut costs. And this is a big cost-cutting maneuver right here. Tobacco and cancer, which is why I'm here. There's a strong evidence over the years, and let's just say the last 50 years, that shows a clear cause-and-effect relationship between tobacco use and cancer. If you go to that report from several months ago, again, look in chapter 6 and tobacco or smoking and cancer, they use the language cause and effect. Cigarette smoking causes colorectal. Then the next thing says cigarette smoking causes liver, specifically hepatocellular carcinoma, primary liver cancer. And then they get down to prostate and they kind of start backpedaling a little bit. In the first bullet point it says, we can't prove that it causes prostate cancer, but the next bullet point says, however, people that smoke have a higher rate of prostate cancer than people that don't smoke. So they backed into it, but you can deduce from that what you will. And then they go on the next line, they spend about 30, 40 pages on breast cancer, about how breast cancer is related to premenopausal versus postmenopausal versus all these different kinds of things. But long story short, tobacco use and smoking has an effect, a direct causative effect on that as well. What cancers are affected? Lung cancer is a no-brainer. You guys have been talking about that already today. You heard testimony about that. It is the primary risk factor in lung cancer. 90% of lung cancers can be associated with smoking. The other cancers that have been associated with tobacco use, and I say specifically tobacco use, somebody asked the question last session, are you talking about cigarette smoking? Are you talking about oral tobacco, or are you talking about cigars? And the answer is yes, all of those. All of those. You know, the old literature was more cigarettes, but now it's the flavored cigars and all this other kind of stuff, and oral smokeless tobacco. All of those contribute to these cancers because these are not direct inhalational effect, except for lung cancer we talked about last. This is direct contact effect, but it's also absorption into the buccal mucosa, directly into the bloodstream. And then it's damage on the cellular level, the DNA level, the inability of the DNA to repair itself and all those kinds of things. And we'll look at that. But this is all tobacco and not just cigarettes. As I said, 90% of lung cancer is caused by smoking. Smokers are 15 times more likely to die of lung cancer than people who have never smoked. And each year, secondhand smoke causes about 3,000 lung cancer deaths. That's significant. That's saying you're dying from lung cancer and you never smoked a day in your life, but you're living with people that smoke. Or you're, especially in Appalachia, where the number of tobacco-free environments pale in comparison to more metropolitan areas, like we were just talking about Nashville or New York, where we look at those smoke-free environments. And that's actually in that report. They talk about smoke-free or tobacco-free environments and where they are and where they don't exist. And they exist less often in Appalachia, especially in rural Appalachia. Same thing we just talked about. Cigars, we're talking about cigars as well. They're directly related to these cancers, and then smokeless tobacco for oral cancers, which I think one of the ENT guys is talking about that during one of these breakout sessions. And as I said in the last session, my wife told me not to put this in here. So, but I stuck from 20,000 feet, we're just going to go through this. So initiation of cigarette smoking, I hope you can see this from the back, nicotine addiction. The reason that is there is because with any drug, you need more and more and more to have the same effect. So that effect accumulates. But really what this is saying is that you got direct toxicity from the cigarette smoke, damaging cells, let's talk about the stomach. You damage the barrier cells. You expose the underlying mucosa to acid and other things that would otherwise not affect those cells. But the mucosa is damaged, and now those cells, underlying cells, are damaged, and you're predisposed to cancer. You get direct effects of the carcinogens to DNA. The DNA is damaged, but the DNA also has the inability to repair itself. Our DNA is damaged all the time, but it repairs itself and through repair genes and all that kind of stuff. Carcinogens impair those cells and the ability of DNA to repair itself. It also, things like apoptosis, that's just a fancy word for your body has a way of shutting down certain cells. It makes those cells die because they don't need to be produced. Cigarette smoking stops that. So now you got cells piling up on top of each other, which is by definition cancer. And then you got cancer down here. These tumor suppressor genes, they exist all over the place. P53, KRAS, so on and so forth. But they're quiet. Everybody has them, but you get a hit here and hit there. And nicotine and carcinogens, they basically give these cells a kick in the pants and get them activated. And once they're activated, they go on to cause cancer in their normal way, but they would not have if if these carcinogens hadn't existed in the first place or hadn't been present to cause that upregulation of those cells. And so then you get lack of growth control, and those oncogenes are turned on, and all those things through a lot of different converging pathways cause cancer. So it's not one mechanism, it's a lot of different mechanisms. Direct cell damage, inability to repair, upregulation of of cancer genes that cigarette smoking or tobacco use causes. I could not make this work last session, but that is the Surgeon General Report, Chapter 6, and it's next to the last page will give you the summary of most of this stuff. Pancreas cancer. You saw on that initial list of solid malignancies that are related to cigarette smoking. I have pancreas cancer on the list. That hits home to me because that's what I do. I take care of patients with pancreatic and liver cancer. Pretty much 50-60% of my practice is this. This is big this week because, and I'll show you the slide, I think it's on the next slide, but currently this is the 4th leading cause of cancer death in this country. 45,000 new cases this year. That actually should be 39 instead of 37,000 deaths. As you know from Patrick Swayze and Steve Jobs and some of the other people that get this disease die from it. Most of them do. This number right here, I said in the last session, has been the same since I started my residency in 1998. It has not changed. We've done a lot of stuff in almost 20 years. We got a lot of new drugs. Like I said, we got robots, we got different surgery. We're doing this surgery laparoscopically, and we got people talking about this stuff all the time, and pages and pages. And that number has not changed one bit. As we were talking about here, prevention, man, you could start wiping out a third of the cancer because it's a third of pancreas cancer because it's or 25% because it's associated with smoking. In pancreatic cancer world, we get excited about a drug that prolongs survival for 2 weeks, and the FDA approves it. 2 weeks. So it clearly is not on the surgery side or on the chemotherapy side. This is a press release from Monday on some research that was published it's published through the Pancreatic Cancer Action Network. Lynn Matresian used to run the research division at Vanderbilt, and now it's part of PanCan that's in California. But she released this statement, and it's actually published in Cancer Research, that pancreatic cancer is going to surpass breast cancer and colon cancer to become the 2nd leading cause of death by 2020. Second. And lung cancer is number 1 right now. Colon cancer is number 2. Breast cancer is number 3. Pancreas cancer is number 4. Pancreas cancer is going to surpass those other 2 to become number 2 on the list. And I put that in there specific. Number 1 is what I'm familiar with, but number 2, there's a direct correlation with smoking and pancreatic cancer. So I wanted to look at the effect that smoking cessation could have on that trend. This is another, and I will not belabor this, is essentially what we saw before, but it's specific to pancreatic cancer. So you have genetic mutations causing pancreatic cancer, you have inflammatory cells causing pancreatic cancer, but smoking affects genetic mutations. It upregulates inflammatory cells that can cause pancreatic cancer. These cells are quiet, as we talked about before, pancreatic stellate cells, but they are turned on by inflammation, which is turned on by smoking, and they cause endothelial cells, which is essentially fibrosis and scar. So even for these patients that get pancreatic cancer, they're hard to operate on because they have all this fibrosis and scar that we can't get out. So smoking doesn't help this process at all. So smoking and pancreatic cancer. It is new in the last 10 years that we started to talk about this. As you will notice in that report from this year, pancreatic cancer is not one of the things they talk about because the incidence is rising so rapidly. In the last 50, we weren't even talking, literally we weren't talking about this when I was in residency. We did a few pancreatic operations here and there, but it just wasn't a big deal. Now it's all of a sudden it's making major press for things that we've known for at least for the last 5 years. 500 PubMed articles. Smoking is the strongest avoidable risk factor that contributes to pancreatic cancer. 25% of pancreatic cancer is attributed directly to smoking. 25%. Twofold increased risk in smokers, and smoking-related risk disappears after, some people say 15 years, but 10 to 15 years, the smoking-related risk can disappear, and it goes down significantly after just 2 years of smoking cessation. So that's just pancreatic cancer directly. But how about chronic pancreatitis, which we know causes pancreatic cancer? Smoking exacerbates the risk of chronic pancreatitis. How about hereditary pancreatitis, which we know causes pancreatic cancer? It can occur 10, 20 years earlier in patients who smoke. So again, multiple different ways that pancreatic cancer is being affected by smoking. And again, that's similar to what we saw before, and I won't go through that. How many people from East Tennessee? Almost everybody. What is this picture right here? It is a Somebody said it's like a radar. Yes, but it is specific to this area.
Ozone.
What is it?
Ozone?
No, it's specific, something that happened here in recent history.
The tornadoes that hit?
That's close, not the tornadoes. What else? In the last 25 years, this happened. All right, this is the blizzard of '93.
The storm of the century.
The storm of, see, all these names, super. So I wasn't here. I came here in 2007, but I was in Winston-Salem when this happened. We just got back from spring break, and we had 6 inches of ice when I got back. 6 inches of ice. I lived in the satellite dorms. We had no electricity, no heat, and we were all cuddled up in one dorm, no classes. It was ridiculous. You know, and I read about this, and they talk about all the loss of power. But anyway, when I got here, everybody kept talking about the storm of '93, and I'm like, what are they? Like you said, what'd you just call it?
Storm of the century.
Storm of the century, superstorm, all this other kind of stuff. So I started reading about this thing. And essentially, the perfect storm is what it was. And so this is what is on the next slide. I don't know if you can see all that stuff on the back. Look at the panel on the left. So everything came together perfect. You got polar jet, you got this cold air. I mean, it was 0, it was 5, it was 3. I remember spring breaks, March. So we got polar jet, you got the cold air, you got the jet stream, you got the moisture, you got the lowest barometric pressures on record in some of these areas, and they came together right over Apple. This dark, for the students in here, this dark blue or royal blue, whatever this is through here, this is Appalachian, up and down, all the way down. All the way from New York, Maine, all the way down to just northern Georgia. So Mount Mitchell, North Carolina got 60 inches of snow. Knoxville got 20 inches. Chattanooga got 12. Record low temperatures, record power loss, as you can see here, 300 deaths, all this other kind of stuff. And I'm like, man, that's awesome. It's not awesome from what happened, but it's awesome how all that stuff came together, especially in this area, and everybody remembers it. And so that's what's happened with pancreatic cancer. The exact same thing. And I say that, I treat these patients, and it is unfortunate, most of my patients don't survive that. But it is the perfect storm from a public health standpoint, from a disease, from a cancer standpoint. This doesn't happen very often in your career that you can study. Number one, you can study. You can be in the middle of it, looking around in the eye of the storm. And then you can participate in it and change it and to redirect. So if you go back and read that report that I had over there from Monday, it talked about that breast cancer and colon cancer are going to fall off the list of the top number 2 and 3 because of what? Why is colon cancer going to go down?
Early detection.
Early detection, screening, colonoscopy. It is curative. It is a screening tool that is curative. Not, it doesn't detect. Mammograms detect. They don't cure. Colonoscopy is cure. They take the polyp out, the cancer goes away. So now we got 50%, 57% of people that get screened, a little bit lower in Appalachia, but colon cancer shrinking on down on the list. 150,000 new cases, actually it's 137,000 this year, 47,000 deaths. That's going down. It used to be 50,000 when I started my residency. How about breast cancer? Same thing. Early detection. We got more women getting their mammograms. We had simple mammograms, now we got digital mammograms, now we got mammograms that do 3D. We got everything. Now, everybody at our institution, if you have a diagnosis of cancer, you get an MRI. So now we find stuff we don't even want to find. Literally, 14% of the time, we find stuff we don't want to see. So that stuff is going to go down, down, down. People are going to talk about it. And Susan Komen, breast cancer's got all the money. They got more money than all other cancers combined because of Susan Komen and Angelina Jolie and all these other people. And then Katie Couric and Katie Couric's husband. Colon cancer. Man, she gets on the CBS Morning News and she's talking about this thing every day, and people start going out and getting colonoscopies and stuff. So that goes away. But where does that leave in lung cancer? Lung cancer, we said less people are smoking, and the death rate. I mean, if just half the people quit smoking, that would go down on this. But here we are with pancreatic cancer, which we said now is number 4, and it's going to be number 2. So that's why I use this example. The perfect storm. Look at this. First of all, there's no cure. Not like colonoscopy and breast. There ain't no cure for this. I'm talking about if you do great surgery, great chemo, get the drugs right, the combination. The average survival is 2 years. 2 years. Okay? I want the surgery, but I don't want the chemotherapy and radiation. Okay, you live 22 months. I want the strongest chemo out there. You live 24 and a half months. That's the story for this. No cure. Then you got alcohol, which is prevalent in this region. You got an aging population. Knoxville is on the baby boomer list of best places to live. It's number 12 in the country. So our population is aging pretty quickly. Diabetes, which goes with obesity. We are the top 5 fattest state in the country, right? We used to be number 3 and 2, and we just flip around with Kentucky and Mississippi and Alabama and so on and so forth. And West Virginia. Poor, we don't have any research dollars because breast cancer's got it all. We got all the attention, colorectal's got all the attention. We already talked about we smoke in this region. It's not 21%, it's probably 30%. That's the perfect storm. That's just like that other picture. Just like the other picture. We're right in here looking around. The question is, what are we going to do? We're not going to get this in, not right now. I can tell you that. That's not, because the focus is on more, better chemo and better. It's too smart for that. I mean, the cells are already changing. By the time we give the chemo, they're already resisting. And we see people that recur 2 and 3 months after they got chemo. I mean, this is not where it's going to happen. It can happen here. That ain't going to happen there. There's nothing to do to stop that. It can happen here. It might, with decrease in funding and what is it, sequestration, it ain't going to happen here either. It can happen here. So that's why I said we have a chance through this conference, through your own institutions, to turn this boat around and go in a different direction. So to make it really personal, this is what pancreatic cancer looks like, and it says and liver, but I took the liver curve off. This is just pancreas, malignant pancreas tumors at our institution since I've been there. This is my MBA project from this year. 2008, we had 122 cases. We had 520-something cases in 2013. 350% growth. There is nothing in medicine that grows 350% in 5 years. Nothing that I've ever seen. This is not nationwide. This is just our institution and what we're seeing. So this is where I've been focused since I've been doing this. When I left MD Anderson and so on and so forth, I thought, man, just do the surgery better. People ain't getting any better because you ain't doing surgery right. Okay, we started doing better surgery. But then we can only operate on 15% of folks because everybody else is metastatic when they present. And then the median spot, and then if you do really, really good surgery, or you send them to somebody at MD Anderson that does really, really good surgery, they still only live 24 months. So that ain't the answer. Okay, you want to do surgery on these folks, but the people that you see, you can't really do surgery on because they smoke. If they smoke, their chance of having a complication, a heart complication, increased by 77%. Their chance of prolonged anesthesia, increased anesthesia, trouble coming out the ventilator, increased. Hard work, increased. Now, we're not talking about 30-year-old people that can stand a little bit of tachycardia. We're talking about 70-year-old people, 65 years. The average age at our institution is 59 and a half for these people that we do these operations on. So the heart's working hard. And then you put it all together right and you pray over it and all that stuff. You put a little glue on it if you want to. And it doesn't stay together because their wounds don't heal because they smoke. So that's a problem. But if they quit, they can get back to where they need to be in a year, but that's too late. But if they quit for 2 weeks, they can even do better. And how about, that's just my fault. How about when we send them the radiation? All the things that the gentleman just talked about that he had with radiation, all that stuff gets worse with smoking. Mucositis, dry mouth, lung damage, fatigue, soft tissue damage, all that kind of thing. That happens anyway, but it gets a whole lot worse with smoking. Chemotherapy. Now it takes more of the drug than you used to need because you smoke, because your vessels are smaller, your tissue delivery is lower. Increased cachexia. My patients can't tolerate any more of this. If I've got somebody with an albumin above 3, I'm pretty happy. Fatigue, infection. They're at increased risk of infection with this anyway, and it happens more often with smoking. Heart and lung issues. So our current strategies, as I said, this has been my strategy to date, and I'm embarrassed to even put the slide up there. Because like I said, I thought we could just do better surgery. This is Matt Katz. Matt Katz actually came up with this differentiation for surgery. He's still at Anderson. And I said, man, that's the answer. So I started stratifying all my patients based on this, and I had a few of these, and I had a lot of these, and a lot of these. And I said, I'm only going to operate on these. Man, it made a lick of difference. Better surgical techniques. Okay, let's do it with the robot. Let's do it laparoscopically. No difference. Let's get better imaging. PET scan was essentially discovered at University of Tennessee. We have the best PET scanner in the world. It ain't making any difference. And chemotherapy and chemoradiation. Okay, you got drugs, and we're going to put them in a different combination and so on and so forth. That's not the answer. So what is the answer? we're trying, so based on this research, based on what we looked at, we're going to build a liver and pancreas, we are building a liver and pancreas program, but it doesn't have anything to do with the people that we already have in our institution. When I started this MBA project, I said, man, we're going to take the people we already have and we're going to coordinate them and we're going to have it streamlined. And so when you call this number right here, pancreas and liver specialist, PALS, you're going to get the nurse navigator, Elaine's going to answer the phone and she's going to take care of all your needs and it's going to be awesome. But the patients are not going to get any better, even if we do all that. And then I said it's going to be comprehensive. And then that word changed. As I was studying for this talk, that word really changed for me, comprehensive. Comprehensive used to be you have chemo and radiation and surgery, all that stuff aligned, and you have it perfect. But really what it means is that this has got to be at the forefront. This was an afterthought for me. I'll admit that. Nutrition, man, surgeons don't think about nutrition. They think about nutrition going to the operating room, but you don't think about it as a preventative tactic so that you don't have to take people to the operating room. Smoking cessation, alcohol cessation, they have classes all the time. I've never participated in one. I've never talked to any of the folks that participated in one because I didn't think that had anything to do with it. This has to be at the forefront of this program to educate folks. We're not going to make a difference probably, maybe in my career, I don't know. But in generations to come, that 25% of patients that have this disease, that we can now, again, turn that boat in a different direction, improve that article from Monday, we can turn that around and make it wrong and make pancreatic cancer still number 4 or number 5 and so on and so forth. Well, we got some problems here in Central Appalachia. That smoking cessation is pretty difficult. Poverty, we know from the literature that people that are impoverished smoke more, period. We have a lot of that here. Poorest region in the country, Central Appalachia. Low educational attainment. How do we educate, how do we talk to them about the importance of smoking? Somebody asked in the last session, they said, I get the smoking and the lung cancer, but help me get the smoking in pancreas and smoking in colorectal and how all those metabolites that we talked about dissolve in the bloodstream. We have to put that in English and get it to our patients and get it to the people that we take care of. You can't bring someone to your doctor's office and leave and go smoke while they're in there seeing me and talking to me. That happens all the time. It has to be a coordinated family effort. And then when you have these smoking cessation sessions, they're not on times or in places that people can actually get to. We have them on the weekends, we have them in the evenings, people need to work and so on and so forth. So we've got to come up with creative ways to get the programs to people that need it. Limited time for healthcare. We got a shortage of healthcare providers in this region. They have a limited amount of time to spend with patients. They're working on the diabetes and the hypertension. They're not working on smoking cessation. Most of them are not. And then minimal exposure to tobacco-free environments. Again, those don't exist in rural Appalachia for the people that actually need it. So now we go back to prevention. We got to talk about abstinence in schools for these guys right here, which is where it's really going to make a difference. Tobacco-free environments. Model being tobacco-free. Our healthcare providers can't be smoking between patients. My nurse smokes. I'll just stand up here and admit it. She smokes. She says she can't go in and take a blood pressure smelling like cigarettes. Contact the patient, contract with the patient. Somebody asked me last session, hey, are you not going to operate on patients if they smoke? I said, well, I don't have the courage to do that right now. I just accept the consequences of the smoking. But I got to get to the point. I said, you know what, if you're smoking, you don't have any skin in the game. All the risk is on me. It's none of it's on you. So until you show me that you're going to stop smoking, we're going to postpone your operation. I have to have the courage to say that. Make smoking cessations program, we talked about that, make it convenient for patients, and all the nicotine replacement programs that we have going right now. This is the big 4 that we talked about in 2014, and this is what it's going to look like in 2030. This is what it's predicted to look like in 2030. But we can change that with some of the tactics that we talked about. So smoking causes cancer. We're sure of that. Everybody said that. The Surgeon General has said that again this year. 30% of cancer deaths alone are related to smoking or tobacco use. We have to avoid controllable risk factors. Will have the greatest impact on current trends. Eating right, exercising, stopping smoking. Not surgery, not chemo, not radiation for me. We must be radical in order to make a difference. And I was telling someone in the last session, when I see people at my tobacco-free campus times 3 years smoking in the corner, our CEO doesn't want us to say anything to them because it'll drive them away. It'll tick them off. Then they won't come back and they won't bring their family back because we're being mean to them. No, I'm being very serious. We had this discussion when we went tobacco-free in 2011 in the committee meetings. How strict are we going to be on this? Not very strict at all. So our goal again is to reverse that. And how do we do that? We advocate healthy living. And when we talk about that, weight control, portion size, smart choices, diminished wisdom, improved treatment options, education awareness. Don't preach to the choir. Like I said in the last session, people that are here are not the people that need to be here. We got to figure out how to get people here that need to be here. Be direct with your patients. You just got to tell them the truth, and you got to be direct. Like for me, I got to say, you know what, we can't do that surgery right now. Waiting room education, the surgeon's general report, entertainment instead of education on your monitor. And I know people are already doing that, but we need to do more of that. And then continue cancer research funding. We have to let our legislators know how important this is for us. And again, as I was saying, up until probably 2 months ago, I would not have put this on there. But I've had a chance to go to Nashville in a previous year, but I had a chance to go to Washington, D.C. this year. And I put this down there, Tennessee Tuesdays, because I wanted you guys to know about it. Every Tuesday, you can go to state capitol and you can meet with your senators. Every Tuesday. Not because you have an important name or initials behind your name. Anybody, any constituent of Tennessee can go and have breakfast with the senators on Tuesday morning. But if really not the senators you want to meet their assistants and their aides. Because those are the people that get in their ear and say, hey man, this lady's been calling me from Sullivan County weekly about the smoking cessation program. We've got to push that legislation through. Those are the people you want to talk to. I went and I sat with Senator Cork. I shook Senator Corker's hand, but I really met with his aide over there over a donut. And then he came to the medical center, and I had a chance to sit on the couch with him for an hour to talk about some of the needs we have. And then he gives me his cell phone number and says, if you got problems, just call me directly. And I'm not going to call him every week. But hey, now you've got direct access to Senator Corker and Senator Alexander. So this is real. This is not something that's made up and I've never seen it before. It's real. So, questions, comments? It's a little bit early. Yes, ma'am.
Did anybody bring up in your other session that Tennessee does have a free quit smoking phone line, 1-800-QUIT-NOW? And there's evening hours and weekend hours. It's funded by the Tennessee Department of Health. Part of my job is to promote the Tennessee Quit Line. I will give you this little pack of.
That's great. So what's the utilization like of that?
Not very much, because it needs to be advertised. It needs to be promoted more.
How do we do that?
Well, the CDC runs some TV ads. You may have seen some that usually have been running in April. I hadn't seen any this year, where you've got testimony from guys like the gentleman that spoke at lunch, talking about, I'm this way, and if I'd only quit smoking, then I'd have my life back. Call 1-800-QUIT-NOW. The health department has run some billboards. They're doing bus wraps, and I think they did it in Knoxville, and they're about to do them in Memphis, promoting the Quit Line. But it's just not enough. Yeah. But if you can hand them out to your patients and give them, give them that number, because they're trained people.
Yes.
They have like masters or counseling credentials. They're trained in helping people work out the plan, and you get a series of free counseling sessions on the phone, and you work it out with the counselor as to what suits your own schedule.
Thank you. Other comments? Hey, we have 6 people in the last session. 15 minutes. Yes, ma'am.
I was just in the pregnancy workshop, and probably the most effective advertisement for the Quit Line is for providers to provide.
Yeah.
And that's what they found with the pregnancy was that providers weren't working with their pregnant smokers, weren't referring them to programs, yet the evidence is that is extremely effective. So
that's a really good point, because like I said, I'll be transparent. I don't know that I've ever counseled anyone with smoking cessation, ever. I mean, I'll say, hey, you need to stop smoking because it does this, this, and this, but not a serious session, or say, hey, here's a hot line, or here are when I don't even know when our classes are, to be honest with you, and they're right on my hall. I mean, our counselor is 2 doors down from me. And so this is an eye-opener for me to say, hey, and we do it in our office just because one of our extenders was in primary care before he came to work with us, and so he naturally does it, but not the oncologist in the office. And I can guarantee the med office and the rad office don't do it either.
So what can we do to change that? So what we're hearing, I work mainly with prescription drug use and prevention. So we're doing key informant interviews now as a part of our research, and what we hear over and even if providers, physicians have the information and the resources, they don't necessarily utilize them. And the number one barrier is their time constraints. So what do we do about that? If physicians can be the, powerful deterrent or refer to treatment, but they don't have the time for it, where do we need to go? How do we change that? Or do we?
That's a good question. I would say, and I'm thinking just on the spot as you're talking, we're looking at, again, going back to part of this MBA, we study lean. We study get rid of non-value-added things and do more value-added things and get rid of the waste. And so in the last month or so, I've changed my office. I've been on time in my office for 4 straight weeks with all my patients. 4 weeks. But that means they come back at their scheduled time. Doesn't mean I see them at 2:45. It just means they're in the office at 2:45, in the room. And while they're sitting in that room, I have them filling out paperwork and risk assessment forms, and maybe part of that can be education, smoking or tobacco-free education, because you need something to do in the room instead of reading Esquire and GQ. Why not read about smoking cessation? I can tell you, it can't be long. It can't be a whole page of anything. But I'm asking how many flights of stairs can you walk up? Do you smoke? And so off that, do you smoke? If they mark yes, then they automatically get this handout or so on and so forth. I don't know what the right answer is, but I know, like we said in the last session, it can't be the same thing we know that what we're doing now is failing. So we got to try something radically different. And I think, like I said, giving people something to do, or having the monitors in your room, setting them up so that something's running all the time, and make them ask you about, hey, if you haven't engaged in a smoking cessation program, your doctor may not operate on you. Man, that gets people's attention. When they're coming to a surgeon, it gets your attention pretty quickly. Yes, right here in the.
I taught a smoking cessation class for 6 weeks. Well, I'm sponsored with one of the corporations, and it's a horrible addiction. I had people who really wanted to quit, and it was a struggle. I think my 39-6 quit, but they started with getting a reduction on their insurance for going to the class, and I got them to team up, with somebody, a buddy at work. If you got somebody to work with you, if you're trying to do it on your own, you really got to be dedicated. Some of these people were really, really addicted, waiting for a break so they could get outside. But if you get them to do something else and get them to do it with somebody, 2 people working together, you can't do that. I know this was, no, we're not going to smoke cigarettes. You have to, it's horrible. Those guys really, really struggled. It wasn't just smoking, it was smokeless tobacco too.
One thing that I do in my practice, unrelated to smoking, is, so it's just like me telling people about how it's going to be to have this cancer. I've never had cancer before.
Well, I've never smoked a day in my life.
Exactly. So you have no credibility.
But now I told them right up front, I've never smoked. The human resources guy didn't appreciate that, but like my husband said, we're going to tell them if they ask you how you quit. I've never smoked, so I told them, but I've lost family members because of horrible deaths because of it. So,
but I think
I had some really gross pictures.
But I think those 6 people that were successful, you now put those 6 people to work. And you have them talk to the other 29, what is it? What'd you say? 31 or 30 that didn't quit. And that's what I do with my cancer patients. I said, dude, I don't know how it is to have a total pancreatitis. I've got a lady in the next room that's had one. She's got her insulin pump for 3 years. Let me have her come in here and talk to you about it. And that goes a lot, going back to your question. What do? You have people that are successful talk to the people that are unsuccessful and walk them through it, partner with them. Because you said got to be more than one.
Yes. They can't do it on their own. They got to have somebody. Unless you're a really strong person.
Yeah. Go ahead. I'm sorry.
I was just going to add to the discussion, the other research with the pregnancy was that physicians didn't believe that it made any difference. And I think it's a culture change with providers, but it also, the same thing applies to not all of us, but we need to spread the word about research, about effectiveness, about evidence-based. We found that parents have the biggest influence in talking with their kids, whether that's about alcohol or sex or drugs or whatever, parents believe they are totally ineffective, so they tend not to. That's one of the reasons why they don't bother talking with their kids. Well, we need to get that, really hammer that in with the data shows that kids listen to parents more than anything else. So you've got to do it. The same thing, people listen to their provider, so we've got to help providers believe that. So.
And we have to help providers to know that it's not really about them. Because you're right, it probably won't help me right now do this operation tomorrow. But will it help you, will it save a bunch of healthcare dollars 10 years from now? Absolutely. And so, we're so crunched for time, you're just in the moment. You're just, hey, I'm not fooling with this right now because it's not going to help me tomorrow. But it's not about tomorrow. And like I said, I'm interested in the trend. I'm interested in making that alive for 2030.
Also, for the outcomes, it may not help ultimately with pancreatic cancer, but it might with that patient, but it might help other members in their family.
Absolutely.
Because that's a huge education for them to find out
Yes.
how much difference this makes, and that you care enough to help this person to stop.
Absolutely. I agree. Yes, sir.
Biggest issue I see is facing this country is our addictive personality, be it food, be it tobacco, be it opiates, particularly here in the Appalachian area. And I think until we refocus back on preventive efforts at preventing these types of behaviors and then providing the supportive care. Right now in this country, we do not pay for preventive medicine.
Yeah.
And until we refocus and bring a lot of our resources to bear on these types of prevention, recognizing, she talked about in the pregnancy, for every $2 million they spend on counseling, they save $9 million in healthcare costs, but the program is too expensive. We've got to bring that back into healthcare as we are an important component in that prevention, and we're going to have to fund it. Right now, we do not have mental health resources, both for opiates, much less for tobacco with cessation or withdrawal. We've got the same problem going on with obesity. It's an addiction problem. And I can speak from that level in that I know what it takes to lose 50 pounds and how hard it is. And it is an addiction that is painful. And if you do not have a support group, use the 12-step like you use with alcohol, you don't have counseling, you don't have group interventions, then these people cannot change. And with poverty and low educational levels, there's no will or motivation. Why?
Let me ask, you said we don't have any current funding for those preventive efforts. Did the exchanges address that?
I was going to say, the new healthcare has a lot of changes with
That's coming, but that's not here.
Well, it's in some of the stuff that's happening. It's just starting since March or all the requirements, but there's a whole lot more, but not so much mental health.
The mental health.
Yeah, definitely. Do you know if the exchanges pay for the cessation classes? That was
I don't know.
We're just starting to see those things.
Skincare pays for Weight Watchers now, so yeah, I would imagine smoking some of it. I mean, we are seeing change. It's not enough, but we are getting.
I don't have places I can refer people.
Yeah.
I mean, I have difficulty finding a place even to send somebody who wants help. I have difficulty as a physician.
Other comments? Thank you very much.